So my name is Lexi MacDonald, and the title of the talk that I'm presenting today is an evaluation of 3D printed models on cardiac catheterization staff education of single ventricle palliation. All right, so before we get into the actual research, what is single ventricle palliation exactly? So single ventricle palliation is a set of 3-stage procedures to essentially take a heart that may look something like what you see on the left-hand image here and turn it into something that is more usable and might look something like the right image over here. And it's performed in children born with a single ventricle anatomy or single ventricle deformity, which can look like many things. But in this specific image, on the left-hand side, we're seeing a mixing of deoxygenated and oxygenated blood, an enlarged right ventricle. And then the 3-stage procedures essentially has the goal of disconnecting the superior vena cava and inferior vena cava from the right atrium, and then reconnecting them to allow pulmonary circulation to flow passively to the lungs. And essentially this keeps the single usable ventricle as a part of systemic flow only, what we can see reflected in the right-hand image. And again, this is performed on children that can be born with varying iterations of single ventricle anatomy. So for a little bit of background and rationale on my project specifically, 3D printing has been really beneficial in the medical realm, and specifically research has shown benefits to patient-provider communication and medical student education. But understanding anatomy is also really crucial to staff education, and understanding traditional 2D images that are seen in the cardiac catheterization setting can require a lot of mental rotation, and it might be difficult for those that are not trained to view these traditional 2D angiograms. Research has also shown that 3D printed models allow for better understanding of spatial relationships, which is especially important when it comes to complex anatomy such as the heart, especially when there are congenital deformities. And single ventricle palliation itself provided a good example for testing our hypothesis due to the complicated and evolving anatomies that are involved at each of these staged procedures. So the aim of our project was to investigate the benefits and drawbacks of 3D printing in single ventricle anatomy education for both cardiac catheterization laboratory staff members and recovery room staff members. And we hypothesized that using 3D printed models of staged single ventricle palliation will provide staff members with more anatomical knowledge than that of the traditional 2D angiograms. So for our materials, we created 2 educational modules. The first being a 2D angiogram module where we took screen captures of 2D angiograms, which is what you're looking at in this left-hand image here. And then we labeled all the major vasculature to help orient staff members so that they could go through this module individually and understand what exactly they were looking at. And then along with these pictures, we provided explanations of the changing anatomy and physiology at each stage. And then we created a 3D printed module as well, where we provided staff members with a 3D print of each stage of palliation created using 3D rotational angiography. And then along with this print that the staff members could physically hold and turn and interact with was the same descriptions of the changing anatomy at each stage, and then screen capture images of the 3D printed models so we could once again label the major vasculature and help guide the staff members as they worked through these modules on their own. So moving on to our methods, we had a voluntary study where 21 participants, including cardiac catheterization lab staff and recovery room staff, participated in a crossover study design with 2 randomized groups. All participants participated in a pre-education survey where they answered questions in rating their own knowledge of each stage of palliation, and then just answering some questions on their level of experience. And then group A completed the 2D module followed by the 3D module, and group B did the reverse. And then all participants participated in the post-education survey where they answered some similar questions, but rated their understanding after interacting with each educational modality, and then performed statistical analysis on these Likert scale results. So what we found here was that the self-reported anatomical understanding of each stage of single ventricle palliation significantly improved from pre-education, which is the reported answers for the staff members before interacting with any education. And then in the orange bar showing the significant improvement is after interacting with the 3D education. So we did see that significant difference in their self-reported understanding, but we did not see the same significant difference after interacting with the 2D module. And then the surveys also allowed participants to provide feedback on what they thought strengths and weaknesses of each modality truly were. So this figure here is the reported strengths of each educational modality, and the blue bar represent that strength was reported for the 3D printed models, and the orange bar represent the percentage of participants that reported that strength for the 2D angiograms. And we found that by and large, participants rated highly the ability for the 3D printed models to provide a good understanding of the anatomy, a good representation of spatial relationships, and a good representation of anatomical details. And this was reported far more frequently, as you can see from everything included in this big box, than that for the 2D angiogram module. And then another interesting finding was that the strength of taking less time to understand was reported at a similar rate for both our 3D printed models and our 2D angiograms. And when I dove into this a little bit more, I found that the majority of those that reported 2D angiograms as taking less time to understand were actually staff members that work in the cardiac cath lab itself. And these staff members have a lot more exposure to 2D angiograms, so it might actually be something that we may expect based on their familiarity with the model. And so in conclusion, we saw that there was significant improvement on staff understanding of really complicated cardiac anatomy when 3D printed models were used as compared to standard 2D angiography images, and that 3D printed models were preferred by the study subjects for their learning. And based on what we found, 3D printed models could play a role in regular staff education in the future. And one of the main reasons why 3D printed models might be a better educational tool is the ability that they have to provide spatial information, as that was a really highly reported strength that the staff members found. But of course, we're not without limitations, as we did have a small sample size, and the amount of time that staff members actually had to interact with the modules may not have been enough. And before opening it up to questions, I'd like to acknowledge everyone on my committee, as they've been really supportive and amazing. It's been super fun to work with all of you, as well as Jennifer, and then the entire 2021 cohort of Modern Human Anatomy students. And with that, I'll open it up to questions.
Great talk, Lexi. That was wonderful. So any questions for Lexi? Lots of applause here. And if you want to, we do have some time if you want to pipe in and just ask your question, unmute yourself. Looks like you gave a crystal clear talk, Lexi.
Beautiful.
All right. So if there are no questions, we will we'll move on to the next talk. So thanks again, Lexi. Great job. And
thank you all.
I have a quick question.
There we go.
You had mentioned that some of the participants had prior knowledge of the angiograms. Were they randomized in groups? Like, did you see which one, you know, did you look at that prior knowledge when you a post hoc in your group?
That's a great question, Dr. Stabio. So we did have participants rate like how much like they have used both 3D printed models and how familiar they are with 2D angiograms in our surveys. And for our analysis, we did separate staff members out into two groups and performed the analysis of each of those results on both the cardiac catheterization staff members as well as the recovery room, with those lab members being the ones that are more familiar with 2D angiograms. And we saw no significant difference in results between the two groups. We also analyzed based on years of experience. We chose 5 years as a cutoff, with more experienced staff members likely being more familiar. And we also saw no difference based on that. But great question. Thank you.
Okay, thank you.